Hello, and welcome to Navigating from A to B and C in Multiple Myeloma, practical workshops on high-quality care with antibodies and BCMA antibody-drug conjugates and cellular therapy. I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, and I'm pleased to welcome my nurse practitioner colleague, Cherise Gleason, also from Winship. Today we're going to explore the team-based management of multiple myeloma, but focus our attention on how to use novel antibodies and BCMA-directed options that we now have to manage patients in frontline and relapsed refractory disease settings. During this program, we will periodically share several resources that can inform treatment selection and safety management. So please take a moment to download these practical tools before we get started. Let's go ahead and begin. So we know that there have been a number of new treatments approved in the last decade for the management of multiple myeloma, and many of these have included immune-based approaches to the management of patients with newly diagnosed as well as relapsed and refractory multiple myeloma. While daratumumab was initially approved back in 2016 and 2017 as a single agent in the context of refractory myeloma, it rapidly was approved in combinations with carfilzomib as well as pomalidomide, and we subsequently had the approval of the subcutaneous formulation of daratumumab as well. After 2020, we then had approvals of isatuximab, either in combination with carfilzomib or in combination with pomalidomide, and subsequent to that, we had the initial approval of belantamab mafodotin, the first BCMA-directed antibody approved in myeloma. And this is an antibody-drug conjugate. Just a year later, we then had ide-cel approved, which is a CAR T-cell directed at BCMA. And just in the last 6 months, we've had cilta-cel approved, which is a different construct, but also a BCMA-directed CAR T-cell. So as you can see, in just a short 5 years, we've had a pretty dramatic change in the armamentarium we have to manage patients with myeloma, as well as the combinations that we use both in newly diagnosed, in maintenance, in early relapse, as well as in the management of late relapsed myeloma. And all of these have led to significant improvements in outcome for patients with multiple myeloma across all spectrums of their disease state. Now we know that despite all these new advantages, improvements in progression-free survival, and probably some of the longest overall survival patients with myeloma have experienced, at least in my career, we know that there remain significant unmet medical needs. And these are several, particularly older patients with multiple myeloma, patients who present with renal dysfunction, or patients who have high-risk myeloma. And if you look at large retrospective series from community-based approaches, what you'll see is that for patients who are not eligible for transplant, so older and frail, over half only receive one line of therapy, which means they're not getting access to all of the great new things we just described on the previous slide. At the same time, if you look at patients who were receiving transplant, and again, that's a relatively small number of the patients that could potentially be eligible for transplant, only 21% received one line of therapy as well, suggesting that they are not getting to the medians that we know in many of these trials of 5, 6, or 7 prior lines of therapy, remembering that many patients in these trials will have upwards of 13 to 20 prior lines of therapy before enrollment on this refractory myeloma trial. At the same token, probably one of the most rapidly expanding unmet medical needs in myeloma is the triple-class refractory patient population, where patients we know experience poor overall survival and have pretty significant impacts on quality of life. And we will talk about quality of life, particularly as it impacts therapeutic treatment selection. But again, 35% of patients with triple-class refractory myeloma did not receive any additional therapy. That's despite the fact that we have 4 to 5 new approved agents in this space. And so I think this really does represent an important educational opportunity to better understand how we can approach treatment in patients who meet these very challenging treatment criteria. So let's start off talking about the role of antibody triplets and quads in the context of newly diagnosed multiple myeloma. We know, for instance, that there are a couple of different scenarios that we have listed here. And Charisse and I will go back and forth on this in just a few minutes when we get through some of the educational materials, but I think they're illustrative cases for a couple of reasons. The first is the case on the left is a 67-year-old gentleman who's got standard risk myeloma, ISS stage 1, clearly has symptomatic myeloma but does not have any high-risk genetics, but does have pretty significant diabetes, neuropathy, and a history of heart failure with a previous history of an MI. And so while this patient, at least on the surface, may be one that we're challenged with in terms of moving forward with a transplant, I think discussions around whether one would consider collection, depending upon response and tolerance of therapy, is certainly an important one. But at least on the surface, this may be somebody we may be less enthusiastic about moving forward with a transplant, despite the fact that by age, I think almost all of us would think that this age criteria would in fact be eligible for transplant. On the other hand, the patient on the right, a 74-year-old gentleman with ISS2 high-risk myeloma, many might take the age alone and say this patient is not transplant eligible. At least at our center and many other major myeloma centers, we would actually not let age be a predictor in this factor, but would look at comorbidities, and this patient has really pretty minimal comorbidities with only well-controlled hypertension, normal renal function, and we know that transplant does seem to offer particularly more benefit in the high-risk group of patients as well. So this might be somebody we would consider to be transplant eligible. And if you thought, looking at these two cases on the surface, that it would have been the other way around, we did that on purpose to really try and illustrate some of the facts that it's not just about age, it's not just about risk or disease status. There are a number of factors that go into making decisions about transplant eligibility versus ineligibility that really should be done in partnership with a major myeloma center. So let's look at NCCN guidelines for the treatment of newly diagnosed multiple myeloma. As you can see on the left, for non-transplant eligible patients, Dara-Lendex is a category 1, bortezomib-Lendex is a category 1. Other recommended include Dara-Cyclo-bortezomib-Dex. As you know, I'm not a fan of cyclophosphamide-based induction regimens, but there is certainly one that does have randomized phase 3 data supporting it, which is Dara with VMP. I think in the U.S., I'm sure we can count on one hand the number of people that have used oral melphalan and prednisone-based approaches, and so I suspect most folks are going to lean towards the left side of the screen in terms of treatment choices and options for patients. If we look at other potential recommended therapies, again, for transplant eligible patients, again, VRD does continue to be the only category 1 standard that we have at this time point. Other recommended include potentially KRD, Dara with bortezomib-Lendex, and then Ixa-Lendex as another potential option, although I think this one's probably getting a lot less play currently, given some of the other potential treatment options that we currently have. So let's look at an update of the MAIA trial, and this is really adding daratumumab to Lendex in non-transplant eligible candidates. And I will tell you, having really looked at this data pretty clearly, my question when I initially saw it was, since they used 65 as the age cutoff, was this curve really improved or enhanced by using a lot of younger patients that in the U.S. we would consider transplant eligible? And what I think is really quite interesting about the MAIA trial is that about a third of patients enrolled were over the age of 75. And so those clearly are patients that are on the border of transplant eligibility. And the absolute magnitude of benefit for DRD over Lendex was the same as it was in the younger patient population, which I think is really important and speaks to the potency of this regimen and that it really could be independent of age. What we know is that the median progression-free survival, at least with the most recent update, is at least 5 years compared to only 34 months for the Lendex arm, and this actually is better than the Lendex arm and many other control arms, and that the overall survival has not been reached, and again is significantly better than the Lendex arm. And you could argue, why are we looking at overall survival in this? Well, remember I told you over 57% of patients with transplant-ineligible patients never get to a second line of therapy. So what you choose for those older, frailer patients may be really important and may ultimately define their survival. That's likely different in a younger patient population, where we know that transplant does offer significant PFS benefit, but that because these patients often get 3, 4, and 5 lines of therapy, overall survival may not be what we expect to see in the context of newly diagnosed myeloma trials in that setting. What we also know is that similar to younger patients, MRD is an important prognostic factor. And as you can see here, patients who had sustained MRD negativity for greater than 12 months had a much better progression-free survival on the left, or overall survival, than patients who were MRD negative for less than 12 months or patients who did not achieve MRD negativity at all. Now note, this is 10 to the minus 5. And so this, in my mind, is a suboptimal endpoint in terms of discontinuation of therapy. But if you're asking about a regulatory endpoint by which we can compare trials, 10 to the minus 5 is certainly reasonable in that context. And if you look at pooled data between the Maya and Alcyone trial, remember Alcyone was VMP plus DARA versus VMP, again, you see that prognostic benefit of becoming MRD negative. This is not really a surprise and does certainly fit with what we know about other treatments in this context as well. Now, before we get to the younger patient population, I do want to take a moment to set what I think is the current standard of care for patients who are younger and transplant eligible in terms of outcomes. And this is data from the RVD 1000 series that Dr. Joseph, on behalf of our group at Emory, published in JCO a couple of years ago. And what she is showing is that the median PFS for all patients, all 1,000 patients, was 65 months, and that the median overall survival was over 120 months, so greater than 10 years. But more importantly, if you look at the median PFS for standard risk patients, it's almost 80 months. And if you look at the median overall survival in this, it had not been reached, with a median follow-up of about 8 to 9 years. Now, we are updating this data at ASCO, but I put this in here as you're going to look at progression-free and overall survival curves from other large phase 2 and phase 3 trials. And remember, this to me now is the benchmark against which those are compared. And so when you look at the updates of this data at ASCO this year, you'll see that, that the data continues to look good, if not, in fact, if not better, with additional longer follow-up. Now, the first trial to discuss is the Griffin Trial. The Griffin Trial was a randomized trial of RVD DARA versus RVD. Patients all had a transplant. They then all got consolidation with either RVD DARA or RVD based on their original assignment. And then patients received maintenance with either len-DARA if they were on the DARA arm, or lenalidomide alone if they were on the no DARA arm. So it was consistent across the way in each of the two arms. And what you'll see is that the depth of response clearly is higher in the group that received DARA throughout. 82% greater than CR compared to only 61% in the no DARA arm. If you look at the end of transplant, 27% were greater than CR compared to only 20%, and clearly the VGPR rates are higher in the group that received DARA as part of the induction, consolidation, and maintenance compared to the group that did not. Now, as you continue to build on this, what you'll see is that over time, this difference translated into significant improvements in MRD negativity. Now, again, this is 10 to the minus 5 for both of these thresholds here. But if you look, DARA RVD was almost 3 times higher in terms of sustained greater than 6-month MRD negativity, and was almost 3 times higher in terms of sustained MRD greater than 12 months. And remember, the endpoint of greatest import is not just achieving MRD, but it's sustained MRD negativity. And in my mind, the minimum duration is 12 months. If you're going to make any decisions or comparisons, 12 months is the benchmark of sustained MRD negativity. And as you'll see on the right side, This is now translating at 3 years into what looks like separation of the curves in terms of PFS between the DARA arm and the non-DARA arm. And just for reference, 81% at 3 years is almost identical to the PFS that we see in the RVD 1000 series. So the control arm is not performing better than we would expect. It's actually performing about as we would expect. And finally, at 3 years, we're seeing the benefit given the efficacy of standard therapy in these patients with newly diagnosed myeloma. Now, we know that the efficacy of DARA-RVD is consistent across all patient subgroups. What you'll see here is that in no group is it to the right of the 1, meaning that in every single subset, it's all on the left side favoring DARA-RVD. You can see that while this is an important randomized phase 2 trial, it is relatively small, and so there is some overlapping of 1 with the confidence intervals, and we're hoping that the Perseus trial will give us more power to confirm some of these findings in terms of benefit for the DARA arm across the board. Now, the other trial, and in fact this was the first trial that came out, was the Cassiopeia trial, looking at DARA-VTD, transplant, DARA-VTD, and then randomization between DARA versus observation, compared to VTD alone, transplant, VTD, and then DARA versus observation. In my mind, this is a flawed trial, and it's flawed because we know observation alone is not adequate in the post-transplant setting. And so where I really use this trial is trying to make decisions on whether or not there's benefit for adding DARA on the front end. And the way that I would measure that is not a PFS endpoint, it's really depth of response and MRD negativity early on in this randomized trial. Now, and in fact, that was confirmed with previous analyses, but what you notice here is that there is some sense when that it doesn't matter when you get DARA. You can get it up front, you can get it in the maintenance setting. As long as you get it, the benefit is seen here. It's patients who don't get it at all, who get no maintenance, basically who have a median PFS of somewhere around 30 months. And remember, this is almost identical with the IFM study where patients were randomized to no maintenance and the median PFS was less than 3 years. So I think that this really is internally and externally consistent and shows that if you're going to get DARA, perhaps you don't need it the whole time. You can get it up front or you can get it in maintenance. You don't necessarily need it in both. Now, I do think it's important to look at other anti-CD38 antibodies in this context. This is the German Hd7 trial looking at ISA plus VRD versus VRD alone. Remember, in this trial, they looked at the endpoint of response at the end of induction. And as you can see here, 51% were MRD negative compared to only 35% with VRD alone. You might be saying to yourself, why is this number so different than what we've seen in every other trial? In the German trial, they gave 6 cycles of induction, not 4. So they basically gave 50% more therapy to allow you to get to a deeper response. We don't know whether that translates into better PFS. There is a historical presumption that it will, but remember, it can be more challenging to collect stem cells after 6 cycles of therapy. So this certainly is something that I think we're looking at that German study to give us additional information on as well. Now, the question is, can these novel quads enhance efficacy in the context of high-risk myeloma? And this is data from a trial also in the German group looking at an interim analysis of just 50 patients that looked at ISA plus KRD induction, clearly demonstrated rapid responses, and at 2 years the PFS was still 75%. And what I think you're seeing is very deep responses, 50% achieving a CR or better among those 46 patients. So I think we need longer follow-up and a larger number to understand this, but certainly this suggests that the quads may offer benefit in the context of high-risk myeloma. So I think I'm going to ask Charisse here to make a few comments as we look at these 2 cases and go back and forth. Remember, this was the younger patient who we said may or may not be transplant eligible, as well as the older patient who we said likely is transplant eligible. Charisse, you want to give some comments on these 2 cases as well?
No, yes, I think you made really good points about the reverse of the ages. So for the younger patient, who has these comorbidities, you're still going to want to give them a multi-drug induction, and you still want to consider collecting those stem cells because sometimes their status changes and they still might be a transplant candidate down the road. So I think you still want to consider something like lenalidomide with DARA and DEX, and maybe even still having DARA RVD in there, just giving it at a different frequency to monitor that neuropathy closely.
Yeah, you know, one of the interesting things that I think we've tried to do is look at induction therapy as a stress test, and so, you know, if there's somebody we're on the fence about, we might think about a triplet or a quad, and if they sail through and respond nicely, that tells us the likelihood of them being able to get through transplant is better. If they really struggle with that kind of an aggressive approach, that might be a clue that they're not going to get to the transplant setting. And this way you're not closing doors, you're not limiting opportunities, and certainly the idea of collection and then potentially trying to improve their performance status and moving to transplant at a later date may be another potential option as well.
No, I agree. And we've seen that in clinical practice. And you might have another use for those stem cells down the road as well. And, you know, I think, you know, we still struggle sometimes with our referrings when we recommend giving DARA up front. You know, Sagar, how do you comment on, you know, when people still want to keep something in their back pocket?
You know, that's a really important question. And part of the reason why we have the RVD 1000 data set is that 15 years ago, when we started using RVD for everybody, when we didn't have all these choices, that was the biggest pushback that we got. Well, what are you going to have when they relapse? And my joke is I sort of think about myeloma as the Doritos commercial. Crunch all you want, we'll make more. We've got lots of new drugs in the pipeline. We're always coming up with new things. There's no reason when the risk-benefit ratio clearly benefits outcomes to hold on to better agents just to save them for later. This is not solid tumor oncology where we really need to think about treatments in this way. And in fact, had we done that, we never would have seen the benefit of RVD triplets and would have continued to be using doublets with or without chemotherapy. And so I think that's one side of the argument, that there isn't a reason to hold on to DARA if it clearly improves depth of response, and that translates into better post-transplant PFS. The second is that if you use DARA as part of your induction, as we do, but don't use it in the consolidation and maintenance phase, you can still use it again in the context of early relapse. So you're not really losing anything. All you're doing is getting an adjunct early on to deepen response and knowing that you can use it again later on. And if the Cassiopeia analysis is correct, if you give it at induction, maybe you don't have to give it in maintenance. Now, we'll see longer follow-up in larger trials to answer that question, but certainly you're not losing anything by saving it, by using it up front briefly and then saving it for relapse afterwards.
No, and in our patient population, we've certainly seen more MRD negativity now in that early post-transplant period since we've been using the quad up front, using DARA up front.
All right. So let's go on maybe talking a little bit about some of the team discussions. As Charisse and those of you who know us have known, we've always talked about the strength of the team in taking care of patients. But I'm going to let Charisse talk through these next few slides.
Yeah, you know, we really do take a team approach to caring for our patients. We have a physician, we have advanced practice providers, our nursing team, our clinical pharmacist, and then we have the extension of our team in our infusion centers. So we see our patients at day one of their treatment, and we have follow-ups with them via the phone and patient portal, but we really count on the rest of our team as well to assess how things are going. And so we want our patients to communicate with us. We talk to them about, let us know if you're having any changes from baseline, and you need to be very specific with patients. Not, sometimes it's just that you just don't feel right or you feel different. But so fevers, rashes, we want to know about those things. We have to explain the REMS program, especially with IMiDs and the requirement that they're going to have to do that monthly survey so they know what to expect. We talk about count changes, and how that's transient. Your counts may drop during the cycle and then come back up. We talk about the need for thromboprophylaxis. So you want to assess whether they have a history of having had some kind of clot, so a PE or a DVT, but also you want to assess their activity level. If you have somebody who just doesn't move, they've had surgery or they've had a lot of pain from bone pain from their diagnosis, you may need something more than aspirin. You may need to consider a low molecular weight heparin or a DOAC for their prophylaxis. We talk about adding, the antiviral on every patient and, antimicrobials as needed, growth factor support. So there's a lot to talk about with patients ongoing with their treatment. In the induction setting, we do tend to prescribe an antiemetic, though quite honestly, we don't see a lot of nausea, but we want patients to have something on hand. And keeping in mind that many of our new patients maybe didn't come in with symptoms. I mean, they have myeloma now, but they're not necessarily sick from it. And so we're adding a lot of new medications to their world. And so really getting them through that first cycle or those first 2 cycles with lots of changes going on and the steroids is, it takes really that team to get them through that. The other thing in thinking about specific to the CD38 antibodies includes, we have sub-Q versus IV administration. And at our institution, we almost have exclusively gone to the subcutaneous. But again, there's a lot of teaching involved in this. So first dose, there's, when you're using subcutaneous, there's a far less likelihood of having a reaction to it, but they still need to be monitored for that first dose for about 3 hours. It may vary a little bit depending on your institution versus 6 hours for that IV infusion. And so these patients may have a history, you want to talk to them about a history of infection when you're on a CD38 antibody. So we want to monitor those immunoglobulins. Sometimes we have to add in IVIG if needed, if they're having chronic infections. For that first dosing too, you want to make sure that you screen for hepatitis B, and you're going to send for a B core antibody as well as a surface antigen prior to that initiation of treatment and initiate prophylaxis if needed. You also want to send a type and screen prior to that first exposure because this can interfere with blood typing if they need transfusion support down the road. And so with daratumumab, you can get a false positive indirect Coombs test. And so it's really important to send that blood type before they're exposed to that.
Thanks, Charisse. I think that was a really good discussion around sort of the team-based approach to management with patients with newly diagnosed myeloma, which oftentimes is such a challenging time for patients and their families because it's a new disease, it's a new diagnosis. They're trying to grapple with a lot of different things. And as good as RVD-1000 makes the outcomes look like, unfortunately, we're still struggling with cases like what you see here, which is the 70-year-old woman with standard risk myeloma who relapses after primary therapy and maintenance, had a good remission of about 4 years, a little bit less than what we would consider the median, and is CD38 naive after 1 to 3 prior lines of therapy. So this is another area where there's a lot of what I would call therapeutic ambiguity because there are lots of treatment options, lots of different choices, loads and loads of randomized phase 3 trials. And what often patients and clinicians are struggling with is what do I choose amongst this large menu of options. So let's talk about antibodies in early relapse into 1 to 3 prior lines of therapy. So if you look at NCCN guidelines for early relapse, you'll see KRD, for instance. You'll see DARA plus VD, KD, PD, or RD. You'll see ISA plus POMDEX or KD. You'll see Ixalendex, you'll see Bortezomib-dex, and then some other ones, particularly the liposomal doxorubicin that I don't think any of us are using anymore. And I think most of us would use selinexor-based combinations, not in first relapse, but likely in later relapse. And so I think when you look at this long laundry list of potential options, the first thing to do is say that a patient progressing on len maintenance, any len-based combination is probably out. So KRD is out. DARA plus Lendex is out. IRD is out. And unfortunately, while I was the first author and led this trial, Elo Lendex is probably out as well. So let's look at other potential options and other ways to think about combining DARA with either a PI or an IMiD and what the data is in that context. So again, we know that using either DARA or ISA in this first relapse setting is the preferred backbone, if you will. And the question is, what are you going to add to it? And these are sort of the choices, as you can see up here. If you look at the CANDOR data, which is DARA plus KD, median PFS was about 28 months versus 15 months with a hazard ratio of 0.59. If you look at DARA plus POMDEX, what you'll see is median PFS of 12 months versus 6.9 months. Now, I will point out that the difference between Apollo and CANDOR is a line of therapy. CANDOR typically was used in the first and second relapse, whereas Apollo was used in second and third relapse based on the indication for pomalidomide. So that might explain some of the difference here. And in fact, in an analysis that Dr. Joseph from our group presented at ASH this year, what she showed was that for patients who are more than 30 months after diagnosis with myeloma in first relapse, that the benefit of DARA-POMDEX was actually significantly longer than 12 months. It was closer to 35 months, I think, in that analysis. So clearly, where you are in the treatment spectrum does, in fact, make a difference. Now, at the same time, you have data on isatuximab plus POMDEX. Again, looks very similar to what I showed you for Apollo before. And if you look at ICARIA, which is ISA plus CARDEX, again, similar. The follow-up was a little shorter on ISA-KD in terms of reaching the median, but again, similar hazard ratios suggesting that this is of equal benefit to what we've seen with daratumumab in the same kinds of combinations as well. So I think what we do know is that longer follow-up from ICARIA demonstrates that the benefit continues to be there. And again, with even longer follow-up, what we're seeing is that the PFS does continue to improve and that the median overall survival is also favoring the group that received isatuximab from the ICARIA study here as well. So again, both of these are demonstrating significant benefit. And the real question is, what are you comfortable with? What do you want to use? What have you used more frequently that allows you to make this decision in a way that does not necessarily challenge or is different for each patient that you see? I think to a certain extent, you do want to come up with a standard go-to regimen in the management of relapsed refractory myeloma. So here we come back to the case, 70-year-old female, ISS2 relapsing after about 4 years, progressing on lenalidomide. Sharice, you want to talk through how we might think about managing a patient like this?
Yeah, this, at our institution, we're going to go to a line of daratumumab, pomalidomide, and dex. But I think it's worth mentioning this is that time point where you do restage that patient. It is a time to do imaging. For us, it's a PET CT. And then look at the bone marrow again to see if there's anything about the disease that's the biology of the disease that's changed. So do they have a high risk feature that maybe they didn't have before? So it's worth taking a look at this point.
Yeah, and certainly given that the PFS was longer than 4 years, I think POM plus DARA would be an option that we would strongly consider. The alternative would be to use carfilzomib as a partner, recognizing that in both the CANDOR and the isatuximab trials, when they partnered with carfilzomib, they gave carfilzomib at 56 milligrams per meter squared twice a week. And so many folks are using 56 once a week. The efficacy and the PFS may not be the same. And so I just want to put that note of caution out there. Clearly, it's a very effective regimen. But I think if you're going to expect and extrapolate from phase 3 trials, you need to know what you're doing differently perhaps than what was done in that trial in case the clinical experience doesn't necessarily map up with what was seen in that randomized phase 3 trial. So I agree. This is not somebody I would use with any of the len-based combinations. CD38 does become the sort of backbone, if you will. And we think about, at least in this patient, CD38 plus POM might be the way that we would tend to go in this clinical situation.
Mm-hmm. Yep.
All right, so Charisse, you want to talk a little bit about sort of some of these things that decide when we think about initiating therapy?
Yeah, no, I think it's important in thinking about this last patient as well. The other things that you take into consideration are how quickly they relapse. That patient was 4 years out on maintenance, but what is the response to their prior therapy, and what are those other comorbidities they might have from the prior therapy? Do they have neuropathy that they didn't have before? So we have to take all these things into consideration. How aggressive is their relapse? Is this somebody that's had a slow biochemical that we've been watching, or is it somebody now who's going into renal failure, has hypercalcemia, new bone disease? Are we having count issues, or has something about the disease changed that now they have a 17p deletion where they didn't before? So you need to think about all these things, as well as, again, what's their performance status? Do they have any new comorbidities? And it's a conversation with your patient as well. In that early relapse setting, we have more options than in that relapse refractory setting. So the things that you always want to consider are their other comorbidities, their frailty, and their convenience. Not everybody lives close to one of our infusion centers, and so some of our patients drive a distance, or can we partner with referring physicians on their treatment? And then again, you want to look at those risk factors to their disease. There's something now that's more aggressive that wasn't there before. So when you're thinking about dosing consideration, so we talked for this patient about going to something like daratumumab. If you look at the subcutaneous versus IV, and remember, you are able to download these dosing recommendations for your use, but subcutaneous, it's an 1800 milligram flat dose versus IV 16 milligram per kilogram. For first dose, sometimes with IV, you have to split the dose, where you don't have to do that with subcutaneous. The administration is weekly, weeks 1 through 8, and then at week 9, you go to bi-weekly from week 9 to week 24, and then it goes to monthly at that point. So it's really convenient for patients, and quite honestly, patients are very sad when they come off of a daratumumab regimen. Giving the subcutaneous, it's 3 to 5 minutes after that first dose, versus an IV infusion of 1.5 hours to 8 hours, depending on where you're receiving it. And so, it's very well tolerated. For patients receiving isatuximab, this is 10 milligrams per kilogram. The infusion rate is about 3.5 hours, and they are looking at subcutaneous versions on clinical trials. The other thing to keep in mind is that hypersensitivity reaction. We talked about this a little bit. There's more of a chance with that dose 1, and it goes significantly down after that. So the pre-medications, if you look, versus IV, sub-Q, and isatuximab are actually very similar between the two. With isatuximab, you do add an H2 antagonist, but and then with dose 1 of daratumumab, we also add montelukast. But these pre-meds really drop off after the first 1 to 2 doses. And, with the subcutaneous daratumumab, we don't continue the giving the diphenhydramine just because it can cause the patient drowsiness, and they're already done and out of the clinic at that point. So early on, and then you can taper off.
All right, so again, another challenging situation that I think we've given some good guidance on in terms of how to manage those patients in early relapse. Unfortunately, the number of patients who get through that early relapse situation and now become triple class refractory is increasing, and to me represents probably one of the biggest unmet medical needs in the context of myeloma. So let's go back to a case, a 74-year-old woman with ISS2 relapsing after multiple prior regimens, having seen PIs, IMiDs, and anti-CD38 antibodies. You can see the treatment, the lines of treatment here. And so I think one of the questions and challenges that we all struggle with is how aggressive can we be given the fact that this patient has seen a lot of treatment, and likely between treatment as comorbidities as well as disease-related issues may have declining functional status. How do we make decisions about how aggressive to be? And on the other hand, there are patients we know that do retain a good performance status, and how do we let that guide our treatment approach, particularly in the refractory myeloma setting? And so I think those are all factors that we think about when we begin to make decisions like this. When we look at patients like this, we do know that in the Mammoth study, for instance, the outcomes in patients who are refractory to anti-CD38 monoclonal antibodies clearly is inferior, and as you can see, triple and quad refractory, penta refractory, all have median overall survivals of less than a year. And these certainly do represent really challenging patients, A, because of performance status, and B, because of counts. Oftentimes they've had so much treatment that their platelet count is low or their white count is low, making it challenging to maintain them on therapy or even get them on potential clinical trials. So what we do know about approved agents in this context is the NCCN guidelines for late relapse, meaning greater than 3 prior therapies. And what you'll see is belamaf or belantamab mafodotin, which is a BCMA-directed antibody drug conjugate, ide-cel and cilta-cel, both of which are CAR T cells, and then selinexor dexamethasone based on studies like the STORM study in this same context of therapy. So let's begin with belantamab mafodotin or belamaf, which is the first in-class BCMA-directed treatment approved by the FDA. I actually had the good fortune to lead this randomized phase 2 trial, which again uses an antibody drug conjugate targeting BCMA, but while it is an antibody drug conjugate, it is actually able to generate ADCC and ADC as well. And for this reason, using partners that enhance immune function, T cell function, and NK cell function clearly make belamaf better. And I'm going to show you some clinical data to speak to that. It is also an off-the-shelf potential treatment option. There is a new adverse event that most of us in myeloma are not used to dealing with in terms of side effects of therapy, and that is ocular toxicity or keratopathy. And Charisse will go over that in just a few moments when we get through some of the clinical data. So let's talk about the DREAM2 study, which is the trial that led to the FDA approval of belamaf in the context of triple-class refractory myeloma. Overall response rate of 31%, with some patients achieving CR and VGPR. The median duration of response was 11 months in the 2.5 mg per kg dose. That is the dose that is FDA approved. And there were patients who did develop keratopathy that required dose holds and dose modifications as a part of that treatment in that trial. What we also know is that partnering belamaf with other drugs, particularly drugs that activate immune function, can be very effective. This is the Algonquin trial presented by Suzanne Trudell at ASH that combined pomalidomide with belantamab mafodotin or belamaf. And what you're seeing is very high overall response rates and very high VGPR or better rates. And so this, to me, again, speaks to the potency of an IMiD with an immune therapy. We see that with DARA, we see that with ELO. We may see that with the CAR T-cell products, but currently we certainly see that with belamaf as well. What about ide-cel? Ide-cel is the first CAR T-cell approved in the context of myeloma targeting BCMA. I won't go through the genetics of the construct or the specifics related to how these cells are made. Just recognize that there was a phase 2 study, the KarMMa trial, that evaluated a large cohort of patients treated with either 450 or 300 milligrams or 300 times 10 to the 6th CAR T-cell infusion. And what we saw was overall response rates of 73%, CR rates of about 33%. Responses were very quick, and I remember the first patient we put on this trial had multiple large plasmacytomas that melted away in the first 24 hours after infusion of the CAR T-cell. Really quite impressive data in terms of speed of response. And what you see is that the PFS in some ways varies based on the target dose as well as the depth of response. And so while the median PFS was around 11 months, certainly patients who have deeper responses are getting longer durations of responses with ide-cel. and this data has been presented and published in a number of different formats. The other CAR T-cell just recently approved was cilta-cel. This is also a BCMA-directed CAR T-cell. This is similar to the Legend product that we saw from China almost 6 or 7 years ago now. It does bind 2 different domains on BCMA, so may have different affinity than what we've seen with other CAR T-cells targeting BCMA. What we know about the CARTITUDE-1 study, based on an updated ASH, is that it had a 97% overall response rate. Median follow-up at 2 years, about 83% achieved CR, and that response occurred relatively quickly as well. But even more impressively, 2-year PFS was about 71% for patients who achieved CR, and 2-year PFS for all patients was about 60%, and 2-year overall survival for all patients in aggregate was 74%. So again, if you go back to the Mammoth study where the median overall survival was 9 months, we've now gone significantly longer with a cell therapy-based approach like CARTITUDE based on the data from the CARTITUDE-1 trial. So let's get back to this case. This 74-year-old woman, depending upon functional status, performance status, and again, her personal preference, we would go through either off-the-shelf approaches like belantamab mafodotin or potentially pursuing a CAR T-cell if availability was not an option and they were willing to potentially accept some of the toxicities that could occur with a CAR T-cell. Shirish, you want to talk a little bit about how we might approach a patient like this in our clinic?
Yeah, it goes back to that, how rapidly are they progressing, and it's all about discussing these options and do we have a CAR T slot available. I think patients sometimes think, we can just go, and we're going to talk about that a little bit, but there's such a process around it to have that patient ready to go. So, you have something like belantamab that would be available to the patient. We're going to look at, do we have something CAR T? And, we always consider a clinical trial as well. So when we talk about the ocular toxicities with belantamab, just to talk a little bit about the dosing. So we know that on the clinical trials, patients can develop this keratopathy, and patients describe it as, I have really dry eyes, I have blurry vision. And so we have to have a baseline vision screen prior to initiating belantamab. And the dosing is every 3 weeks. It's IV with no pre-meds. But the patient has to then again have an eye exam prior to each dosing. And so depending on the grade of changes, they may or may not be able to get treated. And so sometimes, patients are a little leery about that. But what we found is if you hold the drug, typically these issues, the eye issues, do resolve, and so then they are able to get the next dose. So it's not unusual for some of these patients to actually get dosed about every 6 weeks instead of every 3 weeks. And it, usually, like I said, it resolves. We do recommend that they use eye drops, and about 4 times a day. If your patient can't afford the eye drops, then they are provided by the company. So that's something that we can do, or our nursing team can do to get this for the patient. What we did find that on clinical trials, there was no benefit with steroid drops. So there's no use in using that. We're very fortunate that we pair with our eye care specialist, but if there's not that available out in the community, there is a resource to go and look for a pre-identified eye care specialist to help with this. So looking again, just to kind of summarize this, you need to have the ophthalmology exams to monitor for the events, monitor for blurred vision, dry eyes, photophobia. Most of this occurs typically in the first 2 cycles, and it is reversible with holding and then dose reductions. And after a dose reduction and resumption of therapy, you're going to have that continued assessment for not only response, but also ocular issues. And infusion reactions, that's just not been an issue with this, so you really do not have to pre-med. So this is an option, a treatment option for a patient who maybe just wants a treatment that does not involve steroids as well. So something else to keep in mind. So then when we start to think about CAR T therapy, I think we've said, it's as it's FDA approved, it's kind of that one and done, but it's quite the process to get. And the dosing is different for ide-cel versus cilta-cel. But you first have to, have a slot for this patient. So the patient needs referred in to a center that participates on CAR T therapy. And so we typically recommend that you refer your patient in sooner than later. They might be eligible for another clinical trial, but you want to get them into our patient population. So if we do have a slot come up, this is an option for them. Giving the product back, you want to make sure not to use a leukodepleting filter. You want to avoid prophylaxis with dexamethasone or other systemic corticosteroids. You want to monitor for those other adverse events. We think of infection, and we'll talk about that as well, but there are some other toxicities that these patients need close monitoring, and they can last for a while. We keep these patients near our center for at least 30 days before we would send them back to their referring, and just know that some of these toxicities can last way past that time. And so that we have to send these cells off to be re-engineered. So you have to have a pheresis slot. You have to talk about bridging for these patients. If they're going to get bridging therapy, they need to be off of therapy 2 weeks before you collect their product, and then 2 weeks before they get it back. They get in a lymphodepleting chemotherapy regimen, cyclophosphamide and fludarabine before they get those cells back, and that's really to make room for these re-engineered T cells. You get their pre-medications. This process happens in the hospital, so it's really a team approach between the clinic coordination, patient going in the hospital, and then coming back out into the clinic. And while they're in the hospital, you're going to monitor for cytokine release syndrome and neurotoxicities. Knowing you have to be at a center, you have to have tocilizumab available and a REMS program for your center. Sagar, I don't know if there's anything you want to add to that piece of it.
No, I think certainly the challenges really are about adverse events. And so CRS and ICANS, which is neurologic toxicity, does occur in CAR T-cell products. What the good news is, in my mind, is that the incidence and severity is probably 1 grade lower in myeloma than it is in ALL and diffuse large B-cell lymphoma. So the CD19 products, I think the CRS and ICANS concerns are much greater than they are in myeloma. You can see here between cilta-cel and ide-cel, it occurs in almost all patients, but most of it is not necessarily grade 3, grade 4. You can see only 5% grade 3, grade 4. The onset is different based on the product, and that is something that you need to know. And this is very nicely, clearly different between the two. Ide-cel tends to occur quickly, whereas cilta-cel tends to occur about a week later. Even if you look at ICANS, grade 3, grade 4, 2% and 3% for those two. So I think that in many ways this is, it's a new adverse event for those of us who only focus on myeloma, but those who see patients with heme malignancies are used to experiencing CRS, both with bispecifics like blinatumomab as well as CD19-directed CARs, and recognize that these are treatment options that I think typically occur in the hospital. You need to have the infrastructure prepared to manage CRS and ICANS in that clinical situation, and that in most cases it can be managed relatively easily and relatively safely. So I think when we consider principles for CAR T referral, it's not the same as criteria for an auto transplant. I think the adverse events associated with a CAR are much lower. I think our oldest patient is 80, I think, that we've treated with a CAR T cell, and that patient did fine. And so it's not the same functional issue that you see with an auto transplant, but at the same time, referral early is the answer. So when patients are in second relapse, that's probably not a bad time for them to see somebody about getting on a CAR T list and making sure we understand logistics and eligibility, because I can't tell you how many patients I've seen that come to me as a new consult and say, I'm here to get my CAR T cell. And I think our response is, well, there's a process here, and it's going to take us time to get that done. It doesn't just happen overnight. And so I think that early referral really is a key part to the success of getting patients through this process in a timely fashion. So as we wrap up talking about BCMA-directed therapy, it's important to really talk about BCMA bispecifics, because I think this is another off-the-shelf approach. It's very clinically active in an area that I think we're very excited about, and hopefully within the next year we'll have access to this through FDA approvals as well. So I think bispecifics, again, work through a mechanism that is not dissimilar from a CAR T, except it doesn't require the extracellular engineering of the cells in order to be functional. What a bispecific really does is on one side target BCMA and on the other side target CD3, so that you bring a T cell in close proximity to a myeloma cell, and that ultimately results in myeloma cell death. And so I think this is certainly a really exciting and important new area for us in multiple myeloma, an area that's now, I think, exploding in a number of different other cancer targets as well. So probably the furthest along of the bispecifics is Teclistumab, which again is an off-the-shelf T-cell redirecting bispecific antibody. You may hear the word BiTE, you may hear the word bispecifics, but the way that often many of us refer to them is T-cell engagers, or TCEs. And that's basically what Teclistumab is. And as I mentioned, you can see here on one side it binds BCMA, on the other side it binds CD3, and that brings a T cell in close proximity to a myeloma cell, activating it to ultimately then kill that myeloma cell. When we look at data from Teclistumab, as presented by Dr. Moreau at ASH this year, you can see the overall response rate was 62% in patients with triple-class refractory myeloma. About a quarter of those patients achieved MRD negativity at 10 to the minus 5, and about 15% at 10 to the minus 6. So this is pretty revolutionary to think about MRD negativity in the context of a triple-class refractory patient population, with efficacy data that, while may not look quite as good as a CAR T cell, certainly the MRD data looks very, very encouraging as well. What we also know about median duration of response is it's not been reached, but at 6 months and 9 months, roughly 85% of patients remain without progression. And the PFS at 6 months looks like it's about 64%. Median overall survival has not yet been reached. So clearly highly effective with a high overall response rate and very deep responses. I think understanding PFS is going to be really important, and again has the added benefit of being off the shelf. Now, when you think about adverse events, also CRS and neurotoxicity were the two main toxicities that we see, because again this works through activating T cells. But just as I mentioned that CAR T cells are one grade lower than what we see with CD19 directed CAR T cells, when you think about CRS and ICANS with bispecifics, they are also one grade lower than what you see with CAR T cells targeting BCMA-directed targets as well. So ICANS were pretty rare. Most of them were grade 1, grade 2. CRS events were mostly grade 1, grade 2. There was one patient in the phase 2 experience that had a grade 3 CRS that did in fact fully resolve. And we are now looking at stepped up dosing to try and mitigate CRS and ICANS, so that you're not giving the big bolus dose all at one time, but that you're giving slow lead-up doses that ultimately may make this more manageable for patients as an outpatient, which I think ultimately would be a really exciting goal for all of us. Now, if you look at the other bispecific that's out there targeting BCMA, and there are 6 of them, remember, this one is elranatamab, also known as the MagnetisMM-1 study, which is another BCMA-directed T-cell engager with dose escalation, same functional way that it works, similar to what I showed you for Teclistumab before. If you look at 55 patients treated with weekly subcutaneous elranatamab, again, over half the patients were triple-class refractory, with about a quarter of the patients who had seen prior BCMA-directed therapy. The overall response rate was about 70%, And more exciting and I think encouraging is the fact that with step-up dosing and pre-medication, you actually lower CRS significant grade issues. So again, most CRS was grade 1 or grade 2. No events were greater than grade 2, which means that they could be managed pretty easily with corticosteroids and or tocilizumab and still allow patients to stay on therapy overall. I think that this is really encouraging, and it has led to the Magnetism-MM3 trial, which was a randomized trial looking again at patients in different combinations, refractory to a PI, an IMiD, or an anti-CD38 antibody. There are 2 different cohorts of patients, no prior BCMA and prior BCMA, and they're all getting elranatamab as part of their monotherapy in that context as well. So I think it is important when we think about BCMA-directed therapy, whether it's a bispecific, a CAR T-cell, or an antibody-drug conjugate, that we make sure we're talking about appropriate infection prevention. Shirish, do you want to mention a little bit about some of the way that we approach this for CAR T-cell patients in general and in the post-COVID area, how we manage that as well?
Yeah, so for these, post-CAR T patients, they definitely have a compromised immune system. You've re-engineered and used those T cells to target the myeloma cells. So these patients are very hypogammaglobulinic. And so we do start these patients on monthly IVIG just to help boost their immune system and watch those counts and monitor for infection. And that's probably one of the biggest things to monitor for, and know that this is going to be a long-term issue. The other thing with COVID, we want to get these patients on prophylaxis with Evishield. And so all of these patients and our bispecific patients, we want to give Evishield just to give them that extra protection with COVID. And, as we continue to learn more about that, we're fortunate that we've had access to Evishield, and that's gotten a little bit better. But I think considering those long-term infection issues, the other thing just to keep in mind with the CAR T patients too, they can have some neurotoxicities for up to 8 weeks after receiving their cells. So something to keep in mind. This is why they don't drive for 8 weeks. So you have to really have that care partner involved as well in that support in these patients.
Yeah, I think it's, we actually published a paper recently from our group in JCO on vaccine responses in myeloma patients, and the 2 predictors of not responding to the vaccine were CD38 antibodies and BCMA-directed therapy. And so it's not uncommon for Shirish and I to hear from a patient, well, I've had 3 shots and a booster, I'm fine, and we have to remind them that basically they're not going to respond if they're on any of these kinds of therapies. And so prevention, prophylaxis, and telling them to behave as if they're not vaccinated probably is an important message for these patients to minimize the risk of significant COVID infections in this setting.
No, that's right. And we do continue to have those conversations, and patients will ask us to check their antibodies. And frequently you see none, but you don't even know what to do with the data if you do see some antibodies. So we do just reinforce that they need to behave like they've not had any prophylaxis for COVID.
Yeah, no, I think the antibody testing is an important point to bring up, Shirish. And in our paper, what we show is that myeloma patients actually create antibodies that are non-neutralizing. So you can have antibodies that give you a sense of protection, but they don't bind COVID, and so they don't protect you. And so I tell, as you mentioned, we say over and over again, even if you've got antibodies, don't presume that they're going to work to prevent you from COVID in this situation. So lots to think about. And I think as we wrap this up, again, I think this concludes our exploration of our team-based approach in an area where antibodies and BCMA-directed therapies, cell therapies, bispecifics are really playing a central role in patient care and management. We are pushing the boundaries of depth of response in every phase of treatment. We're pushing the boundaries of progression-free and overall survival for patients, and these are all good things, and these are opportunities that everybody wants to be able to provide. And so thank you, Shirish, for joining today as we showed sort of how we take care of patients in our clinics and in our situation. I hope you found this activity informative and useful in your practice, and thank you for your attention.
This activity is certified by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Remember to download the slides and practice aids.